Good morning, everyone. Uh, it's my pleasure. I am Xiao Dong, and currently I'm a Ph.D. student at School of Biomedical Informatics from University of Texas Health Science Center at Houston. And today it's my pleasure to introduce a tool to normalize COVID-19 testing names to LOINC codes. And this tool is called COVID-19 TestNorm. Okay. So this study it's a multi-site study, and our paper has been accepted by JAMIA and is freely online available now. Also, our tool is online available in two forms, and the first one is web service. It's available along with our client website. The second one is the source code is also available by GitHub. So the rest of my talk, I will introduce the COVID-19 TestNorm tool. I will introduce this tool from the following aspects. So first of all, let's talk about why we are doing this project and why we are trying to normalize the lab testing names of COVID-19. So first of all, the coronavirus disease 2019, which is short for COVID-19, was declared as an epidemic by the WHO on March 11th, 2020, and it has become a serious global health crisis since then. So we can see from this picture that by yesterday, there have been more than 11 million confirmed cases all around the world, with 528,000 deaths. And almost all the countries are affected by this pandemic. And as stated in Science, it is more important than ever for scientists around the world to openly share their knowledge, expertise, tools, and technology right now. And researchers worldwide have worked diligently to understand the mechanisms of transmission and action for COVID-19 and to discover effective treatments and interventions. One important data source for COVID-19 research is COVID-19 patients' clinical data stored in EHR. And several consortia have been formed to construct large clinical data networks for COVID-19 research, including for example, the National COVID-19 Cohort Collaborative, which is short for N3C, and the International EHR-derived COVID-19 Clinical Course Profiles, which is 4CE, and many others. And to efficiently conduct clinical studies across different institutions within a network, one requirement is to normalize the clinical data to common data models and standard terminologies. And one such example is the ODC network, which is Observational Medical Outcomes Partnership, and maintained by the ODC consortium. So right now we know the large scale collaborative is very essential during the COVID-19 research. But why the lab data is important? And as showing this picture, there's only one way to get the United States back to work. It's testing, and more testing. And also, as stated by the HHS, which is United States Department of Health and Human Service, the importance of lab data, including lab data, can be a support of decision making, and it also help with impact evaluation on vulnerable population, and also provide vital guidance for mitigation and control activities. Also, among different types of clinical data, COVID-19 diagnosis tests are critical for all the following analysis, as they are the primary means to identify the confirmed COVID-19 cases. So to address the urgency of the pandemic, individual institutions have created local names and local codes for those new COVID-19 tests in their EHRs. And meanwhile, the LOINC, which is Logical Observation Identifier Names and Codes, it is a widely used international standard for lab tests, has responded quickly by developing a new set of standard codes for COVID-19 tests to get standard coding of these tests in clinical settings. However, there is a lack of mapping between local COVID-19 test names and standard LOINC codes. And this situation hampers cross-institutional studies that rely on normalized clinical data at each institution. Right now, existing natural language processing systems such as MetaMap or CLAMP can provide some concept mapping functions, but none of them has been updated to accommodate new concepts for COVID-19 tests. So that's why we are doing this project. To address this urgent need for reliable mappings, we developed an automated tool, which we called it COVID-19 TestNorm, to normalize a local COVID-19 test name to standard LOINC code. And this tool, as I mentioned before, is available to the community freely via an open source package at GitHub and via an online web application. And this tool is a rule-based system to automatically normalize a local test name to a LOINC code for COVID-19. And this figure shows an overview of the modules of the COVID-19 TestNorm system. It mainly includes entity recognition and LOINC mapping modules with inputs from knowledge components such as lexicons and coding rules. And also the input text lab testing names are tokenized first, then specific entities are recognized and appropriate LOINC codes are automatically mapped based on the coding rules. So we collected COVID-19 test data from 8 healthcare systems across the United States, including University of Texas Physicians, Memorial Hermann Health System, University of California, San Diego, Mayo Clinic, University of Florida, University of Minnesota, Columbia University Medical Center, and the National Department of Veteran Affairs. The VA system provided 170 medical centers and 1,063 outpatient sites. We collected those data in April 2020. And data from each institution primarily contain testing names as well as other fields available in local lab tables, such as specimen information. And in total, we collected 568 records from the eight sources. And although some institutions provided LOINC codes with the names together, we did some manually review of the records and assigned corresponding LOINC codes. We have 2 annotators follow the LOINC COVID-19 coding guideline and manually mapped the 568 records to LOINC codes. And the agreement between the 2 annotators was 99%. We then randomly divided the dataset into a development dataset and a test dataset. Our tool, COVID-19 TestNorm tool, was developed using the development dataset and evaluated on the test dataset. And for the design of the entity recognition, because LOINC describes each concept using 6 primary axes, which are components, system, method, time, property, and scale, some of which were included in our COVID-19 entity categories because we developed our category based on their axes. So our 5 root categories were component, system, method, quantitative, or qualitative. This category defines if a test returns a qualitative or quantitative result. And another category called institution. Each institution specifies the manufacturer of the testing kit. The reason why we include this category because the LOINC team, as long as the CDC, has worked with several in vitro diagnostic test kit manufacturers and commercial labs to develop and assign special LOINC codes for them. So we need to include those names for accurate mapping, for more accurate mapping. And furthermore, from the manual review of the training set data and coding rules by LOINC, we identified that accurate mapping requires more specific values under each root category. For example, for system, which refers to the testing specimen, we can find that serum or plasma, saliva, nasopharyngeal specimen, or any respiratory specimen, or even unknown specimen, can lead to different LOINC codes, since the corresponding test method may vary. So in this case, these subcategories of the root category system are essential elements for accurate mapping. So this findings also applies to the other root categories. And as a result, we divided 5 root axes into subcategories. And this table lists all the detailed entity categories used in our LOINC coding system, as well as some corresponding examples. For example, we can see Abbott as a manufacturer is under the institution root category. And also the blood, serum, plasma can be examples of the system, a root category system and subcategory blood. And once the entity categories were defined, we further analyzed the development dataset and manually extracted the related terms for each category. Then we built our lexicon based on the LOINC guideline, the CDC guideline, as well as the entity we extracted from our training dataset. Then this lexicon file is also publicly available together with the COVID-19 TestNorm package. So potential users can manually revise the lexicon file to further improve COVID-19 TestNorm performance on their local data. And overall, the entity recognition step consists of 2 main steps. The first one is an initial step that combines dictionary lookup and regular expression matching. And the second step is a disambiguation step that converts the ambiguous text from the initial step into the final text according to a set of predefined rules. And during the initial step, most information can be captured and tagged to its corresponding category. But some ambiguous words need to be further reviewed. For example, the word IA can be either mapped to a method which represents the abbreviation of immunoassay or to a system which represents the state Iowa. So in this case, we developed context-based rules to determine the correct semantic categories for those terms. And the LOINC guidelines for COVID-19 tests were followed to guide the development of the initial coding rules, which consists of decision-making algorithm based on the extracted entities in the previous step. The coding rules were then iteratively updated using the development dataset collected across institutions. And this figure shows the overall decision workflow based on the coding rules. It starts with the checking if there is a manufacturer information. Specific LOINC codes are assigned to known testing kits by specific manufacturers. And if no specific manufacturer information is available, the tool continues the mapping procedure using testing purpose rules. 5 testing purpose rules are defined based on the tagged entities for component, method, system, with the following information. The first is we can see we are checking for the RNA, sequence, antigen, growth, or antibodies. And for each testing purpose rule, specific tag entities are further checked as the analyte, specimen, method, or whether or not it is qualitative or quantitative. And finally, we can find a proper LOINC codes for a specific input text. And then for the evaluation, we developed COVID-19 tools using the development set, which contains 454 records and evaluated its performance using the independent testing set, which contains 114 records. And we compare the system output with the manually auto-annotated gold standards and reported the accuracy of the system. And we define the accuracy as the percentage of correct LOINC codes generated by the system. And here are the results. This table shows the distribution of different COVID-19 test LOINC codes on the full annotated dataset, which contains the 568 records. And we can find that there are three codes which are 94759-8 and 945000-6 and the 94309-2 were the most frequent codes across institutions, and of which the most frequent one covers over 40% of occurrence in the collected dataset. And all these three codes represent tests for COVID-19 RNA testing using nucleic acid amplification with a probe-based detection method and without specifying any gene or region being tested. So the 94500-6 code is used for tests that can be run on a variety of respiratory specimens. And 94759-8 is specific for nasopharyngeal specimens. And 94309-2 is for unspecified specimens. And all of the three codes refers to a NAA, which is a nucleic acid amplification method. So which refers that this testing method is the most commonly used so far across 8 resources. And in addition, we also counted the number of unique testing codes at each site. As shown in this figure, the number of unique tests at each site varied, with Columbia University Medical Center at the top, probably indicating that many testing methods have been used in this center in New York City. As we know that in April, that New York City is the most serious location of the COVID-19 in the United States. And the overall accuracy of the COVID-19 TestNorm on development set was 98.9%. And when evaluated using the independent test set, the system achieved an accuracy of 97.4%, indicating that the rule-based approach was effective in normalizing COVID-19 test names to LOINC codes. And we also did some error analysis. We can find that we have two missing mapping, and one was wrongly mapped to another code. So for the two missing mapping, both were missed because they don't contain a key entity of COVID-19. Because in our rule or in our system, we define that keyword of COVID-19 must be present in the text. Then we can continue for the mapping. The keywords can be COVID-19 or SARS-CoV-2 or COVID-19 related or SARS related or something. But we can see from the two missed mapping, both of them missed the keywords. So our system didn't map them to any of the LOINC code. But in the future, we may leave this constraint if we assume that all the test name input in our system were COVID-19 related. And also for the third one, for the code 56831-1, the original local test name were patient symptom SARS-CoV-2. This does not contain any specific testing information. And COVID-19, our tool just assigned it to 94309-2, means a very general code of COVID-19 RNA testing without any specific specimen. But so our system doesn't understand why 56831-1 was provided. probably due to some additional information available to the local hospital only. And there is a video, a short video showing you how to search through our web surveys at the claimed website using this service. And see, this is a test demo. We can input any test names. For example, the COVID-19 antigen. Click on the mapping, and then the code and long common name will be returned to you. So we can see that the COVID-19 antigen was successfully mapped to 94558-4, which with the long common name as SARS coronavirus antigen in respiratory specimen by rapid immunoassay. So in this study, we have some advantages. For example, we collected lab tests from 8 healthcare systems across the country, and we developed a simple but effective normalization system for mapping COVID-19 lab tests to LOINC codes to facilitate rapid research response to the pandemic. And this tool is also publicly available with source code. And for ease of use, we also developed a web application so that end users can easily map their local COVID-19 lab testing names to standardized LOINC codes using the online form. So improving the efficiency of multi-center data aggregation and global knowledge sharing. And also, in addition, although we primarily designed the COVID-19 TestNorm for secondary use of EHRs for research purpose, the tool could also be useful at clinical operational setting or public health agencies as well. Unlike large academic medical centers included in our study, many other community hospitals, federally qualified health centers, non-academic medical centers, and also clinics are much less familiar with the difficulties in harmonizing data across multiple systems. And by the time of June, the United Department of Health and Human Services just announced a more rigorous standard for reporting of lab testing of COVID-19 using LOINC codes. So our tool could be a handy tool for improving COVID-19 lab reporting quality for both healthcare providers and the public health agencies. And one of the limitations of study is that even though we collected data from 8 large healthcare systems across the United States, the sample size and data heterogeneity could still be limited. So for example, all codes in our dataset are about molecular or antibody tests. So with new tests available in the market, the LOINC code sets for COVID-19 are evolving. And our future work that the tool will be timely updated with the updates of LOINC and CDC guidelines. As far as I know that the LOINC guideline is regularly updated at least once a week. And also the CDC guidelines containing the manufacturer case names and the mapping rules are also regularly updated, so that our tool will also be regularly updated at a weekly basis accordingly. And when large and diverse samples are accumulated, in the future we will also look into more sophisticated machine learning approaches for this task. And last, I would share some affirmations from social media after our paper is publicly available. And we can see that the affirmations are from all the C network, also from the LOINC teams and HIMSS India. And thanks to all the affirmations. Okay, thank you so much. Any questions?